Bismillahirrahmanirrahim. Today we will discuss the growth hormone and the pituitary adenoma, which is a benign tumor that particularly involves the somatotrop cells that produce growth hormone. Growth hormone, as we know, is released in response to the growth hormone releasing hormone that comes from the hypothalamus, and also there is another inhibitory hormone known as the growth hormone inhibitory hormone that also comes from the hypothalamus, and that is known as the somatostatin. Now, as we know that the pituitary gland contains different populations of cells known as the trop cells. So the somatotrop cells are is that population of the cells that produce growth hormone. In addition to somatotrop cells, there is another population known as the mamosomatotrop cells that produce growth hormone as well as prolactin. Now, before going to discuss the adenoma, the benign pituitary tumor that arises in the somatotrop cells or mamosomatotrop cells, and that will cause excess secretion of the growth hormone. Let us see what happens normally. As I mentioned, the hypothalamus secretes two types of hormones. The growth hormone releasing hormone, which stimulates the anterior pituitary to cause secretion of the growth hormone known as the somatotropin. But there is also an inhibitory factor released by the hypothalamus known as the growth hormone inhibitory hormone or somatostatin that will inhibit the secretion of the growth hormone from the anterior pituitary gland. The growth hormone has some effects that it directly exerts on the body tissues, but in certain organs like liver, bones, kidney, pancreas, the growth hormone causes the release of another hormone which is known as the somatomedin C or insulin-like growth factor 1. And the combined effects of growth hormone and somatomedin C or insulin growth like growth factor 1, they are relatively the same with little differences. Now, the major effects of the growth hormone as well as insulin like growth factor 1 is that it increases the blood glucose level, causing hyperglycemia. Now, how do they do this? They increase the gluconeogenesis, which is formation of glucose from non-glucose uh, constituents, and also increase glycogenolysis, that is the breakdown of glycogen into glucose. On the other hand, the growth hormone decreases the tissue glucose uptake and its utilization. So what happens that in this way the growth hormone causes insulin resistance. There is insulin, but the tissue doesn't respond to it. So in one way, it increases blood glucose concentration by stimulating the gluconeogenesis, which is glucose formation from non-glucose constituents. And on the other hand, it causes insulin resistance. So both of these conditions lead to uh, elevated blood glucose level, and the same is the situation that occurs in diabetes mellitus, and this effect of the growth hormone is known as the diabetogenic effect of the growth hormone. Growth hormone also increases the breakdown of the lipids, lipolysis, and make fatty acids available for use. And in this way, the ketone bodies level in the blood is increased, like acetoacetic acid, beta hydroxy, butyric acid, acetone. So it is also known as ketogenic because it increases the breakdown of the lipids. Growth hormone increases amino acid uptake by the muscles, particularly in retaining nitrogen, and these amino acids are used in the synthesis of proteins, and this effect and growth and buildup of protein in the muscles is known as the anabolic effect. Now, as I said, growth hormone has got some direct effects, and some effects of the growth hormone are mediated by the insulin like growth factor 1, somatomedin C, that is produced by liver, pancreas, kidneys, and bones, and that carry out some of the functions of the growth hormones. As I said, growth hormone increases glucose formation in the liver by stimulating the gluconeogenesis, and on the other hand, it increases insulin resistance. So it is harder for the cells to utilize glucose. So both of these conditions result in elevation of the blood glucose level known as hyperglycemia. And a situation like diabetes mellitus is produced. And for this reason, this effect of the growth hormone is known as the diabetogenic effect. The second effect of the growth hormone direct effects is the increased amino acid uptake retaining nitrogen, and these amino acids are used in the synthesis of proteins, and they aid to the growth of the muscles. Growth hormone also stimulates the bone forming cells or osteoblasts. There are two types of cells, osteoblasts and osteoclasts. So osteoblasts are involved in the new bone formation, while the osteoclasts, they cause breakdown of the bone. So by stimulating the osteoblast, the growth hormone causes thickening of the bones, and uh, this effect, particularly if it occurs in children and adolescents before their epiphyseal closure, will result in the condition known as the gigantism. The indirect effects of the growth hormone are mediated by the somatomedin C or insulin-like growth factor 1. Like growth hormone, the insulin-like growth factor 1 promotes cellular metabolism. It inhibits apoptosis or cell death, and it accelerates cellular division or proliferation and differentiation of the immature into mature cells. And this insulin like growth factor 1 is the key hormone that will stimulate osteoblasts, and if uh, in children and adolescents, if the epiphyseal closure of the bone has not taken place, it will result in increasing the length of the long bones and gigantism. As I mentioned, that the somatotrop cell adenoma is the second most common type of pituitary adenoma. The first most common type of pituitary adenoma is the prolactinoma. And as we know that the anterior pituitary gland contains two populations of cells. The somatotrop cell population produce pure growth hormone, while another population known as the mamosomatotrop cells produce a mixture of growth hormone and prolactin, the milk producing hormone. So when there is excess secretion of the growth hormone, what happens that there is abnormal glucose tolerance and diabetes. As we mentioned that the growth hormone will increase glucose formation by gluconeogenesis in the liver, and it will also cause insulin resistance, and both of these conditions will cause elevated blood glucose level, the same situation that occurs in diabetes mellitus, and this effect of the growth hormone is known as the diabetogenic effect. Growth hormone also increases the renal reabsorption of sodium. Now, when the sodium, which is followed by water, is retained, it will increase, uh, it will cause an increase in the total blood volume, and it may lead to hypertension. Moreover, the growth hormone may increase the sympathetic tone of the blood vessels by causing accelerated and excessive uh, bones uh, and the changes that are induced by the under the effect of the growth hormone in the joints will cause an imbalance, and the person becomes more prone and susceptible to arthritis. Growth hormone may also cause osteoporosis, which is the early and rapid breakdown of bone by the osteoclasts. And by increasing tissue growth and growth of the organ, growth hormone may cause cardiomegaly, and it may lead to congestive cardiac failure. As I said, some populations of the cells known as the mammosomatotropes produce growth hormone as well as prolactin, and this may lead to hyperprolactinemia that may cause galacturia in females and gynecomastia in males. Now there are two situations. Usually at the age of average around 20 years, the epiphyseal plates of the long bones, they close, and there is no further growth in the length of the bones. But if the excess growth hormone secretion occurs before this age, before the epiphyseal plates have been closed, so it will cause an abnormal elongation of the long bones like humerus, tibia, femur, and it will result in an abnormal height of the child and adolescent. And this response, known as the gigantism, is usually it happens dramatically. The child is having more height as compared to his colleagues of the same age. Additionally, there is generalized increase in body size, weight gain, and the long arms and legs are not proportional to the increase in the body size. The other condition in which will occur after the epiphyseal plates have been closed. So there can be no increase in the length of the long bones. If excess secretion of the growth hormone occurs in this situation, it will not result in gigantism, but it will release into another abnormal condition known as the acromegaly. In this type of situation, the major difference between gigantism and acromegaly is that in gigantism, the person or the child is abnormally tall, while here the growth in the bones occur on their transverse diameter. In acromegaly, the growth mostly affects the soft tissues, the skin and viscera, and the bones of the face, hands, and feet become abnormally wider and thickened. So, the symptoms of the gigantism appears dramatically, but that of the acromegaly may take many years before they are prominent. In any condition, the abnormal growth will result in case of gigantism into the growth of the long bones, and the child or adolescent may be abnormally tall. And if the epiphyseal plates have been closed, there will be growth of the bones in the hands, feet, and the lower jaw, which may appear protruded. The forehead of the patient appears protruded forward, and soft tissue swelling in the hands, feet, face, and tongue will occur, so it will result in increased size of the tongue. Generally, there is increase in the size of the organs, and the person may suffer from excessive sweating. Enlargement of the hearts may lead to cardiomegaly and may lead to congestive cardiac failure. Now, these situations may lead to secondary effects. For example, the carpal tunnel syndrome, which occurs due to pressure on the median nerve in the hands and wrist joint. And here, this increased pressure is due to the increased mass of the muscles on the median nerve, and that may result in carpal tunnel syndrome. As I said, diabetes mellitus occurs due to insulin resistance and increased glucose formation due to gluconeogenesis. Congestive cardiac failure will occur due to enlargement of the heart due to gain of the muscle mass. People with acromegaly have an associated increased risk of polyps and the large intestine. Polyps are adenomatous benign growths that occur in the large intestine, and these are potentially they can lead to adenocarcinoma of the colon. So, patients of acromegaly and excess secretion of the growth hormone develop colonic polyps and are at risk of carcinoma of the colon. The mass effects are caused by the presence of pituitary adenoma, and there may be headache due to stretching of the meninges, and since the adenoma, the pituitary gland is located near the optic chiasma, so pressure on the optic nerve may result in problems associated with the vision, which may lead to bitemporal hemianopia, and also known as the tunnel vision, in which we can't see on the lateral sides of our visual field, and it looks appear just that we are looking into a pipe. The sides are not being clear. So you can see that this uh, child with gigantism is comparatively taller than another child of the same age. While in acromegaly, there is flattening of the face, skull, hands, feet, and the person's facial appearance becomes abnormal. And here you can see that the soft tissue swelling can also be seen in the hand when we compare it to the normal hand. Now, how will we diagnose somatotropin adenoma? As I mentioned that the symptoms in these conditions, they appear comparatively late, and particularly that of the acromegaly appears very late. So by the time if there is a pituitary adenoma, by the time we go on to diagnose it, it has gained substantial size. We will start from the signs symptoms of the patient, and we will measure growth hormone, and since growth hormone is secreted in a pulsatile pattern, so its plasma levels are not very stable. Comparatively, the insulin like growth factor 1 remains in a comparatively stable form, and we usually measure the insulin-like growth factor 1. Since to exclude that the adenoma is producing also prolactin that will occur in adenoma of the mammosomatotroph cells, so we will also measure the prolactin level. Since prolactin inhibits the gonadotropins, and if there is a prolactin secreting adenoma, it will suppress the gonadotropins FSH and LH, and we must also measure the serum level of these hormones. Since the thyrotropin releasing hormone or TRH, which basically increases TSH or thyroid stimulating hormone secretion from the anterior pituitary, sometimes also accelerate the growth hormone secretion, and therefore we also measure the TSH levels and TRH levels. For the confirmation of MS or adenoma and its size, and to make an assessment, we do X-ray, computer tomography, and MRI for tumors, and unfortunately, if there is pituitary apoplexy or other situations, we may use these imaging techniques to make an assessment. Very important test that we do not only for growth hormone but also for glucose tolerance. If we are confused that either we should put the patient as diabetes or not, so to find out a pre-diabetic condition, we do this oral glucose tolerance test, and we use also this test for the presence of, for the confirmation of the excess secretion of the growth hormone level. Normally, when the blood glucose level runs high, it should suppress the growth hormone level, because hypoglycemia and low blood glucose concentration in the serum is a stimulus for the growth hormone secretion, while hyperglycemia or high blood glucose level will suppress the release of the growth hormone. So what we do, that we advise the patient for an overnight fast, not to take his dinner, his breakfast, and when the patient comes, nothing by mouth, we take a sample of blood and we measure the level of the growth hormone as well as that of the blood sugar. Then what we do, that we note this level of the growth hormone level that we have done when the patient was fasting for the last 8 to 12 hours. We mention it, we note it down, and then we give 75 grams of standard glucose, which is dissolved in 300 milliliter of water. It may make 3 or 4 glasses of water, and we advise the patient to drink it gradually so that he may not vomit. After taking this 75 gram of standard glucose dissolved in 300 milliliter of water, we tell the patient to wait for 2 hours to make sure the absorption of glucose into the blood and to exert its effects on insulin as well as on growth hormones. Now after 2 hours, we again take blood from the patient, and here we level the level of the growth hormone. Now what we expect? Here in this condition, the patient was hypoglycemic, and hypoglycemia is a stimulus for growth hormone secretion. So in this condition, we will expect a high level of the growth hormone. But after giving the patient high level of glucose after waiting for 2 hours, if we measure the growth hormone level again, it should have been suppressed. This level should be much lower than this one. But if this level was elevated and this level is also elevated, this means that the loading dose of glucose failed to suppress the growth hormone level in the blood. And here we can say that this growth hormone secretion is due to a somatotrop cell adenoma or tumor of the growth hormone, and it doesn't respond to the blood glucose level. In a healthy person, normally the growth hormone should be less than 5 milligram for men and less than 10 milligram for women. However, in children, they are growing and the range 0 to 20 should be taken normal, and particularly in newborn, the up to 14 milligram per milliliter level is considered normal. But when we give the loading dose of glucose, then it should have been reduced to less than 2 milligram per deciliter. And if it still remains high, this means that there is a pituitary adenoma, somatotrop or mamosomatotrop cell adenoma that is secreting growth hormone. We can also stimulate the growth hormone secretion by giving the patient glucagon, arginine, or insulin, and glucagon will cause increased blood glucose level by stimulating glycogenolysis, and when the blood sugar level will run high, it will stimulate the growth hormone secretion. If the growth hormone stimulation test, if we get if we success to elevate the growth hormone level up to more than 10 milligram per deciliter, so it confirms that the pituitary is normal. And if we fail to stimulate the growth hormone level and if it is still less than 5 milligram per milliliter, this may lead to hypopituitarism, that there is some problem in the pituitary gland that is not producing proper levels of the growth hormones. After the somatotrop cell adenoma, the third most common adenoma is the corticotrop cell adenoma. And as we know that the corticotrop cells are those population of anterior pituitary cells that respond to corticotropin releasing hormone, and these corticotrop cells, they will produce adrenocorticotropic hormone, and adrenocorticotropic hormone will flow in the blood and it will act on the adrenal gland and will cause the release of cortisol. If the excess release of cortisol, if it is due to a pituitary adenoma, then we will call it as the Cushing disease. But if it is not due to a pituitary adenoma and other conditions, for example, if a patient with some chronic immune disorder is taking corticosteroid treatment, so he will also be having cortisolism, but he is not having a pituitary adenoma. In conditions of benign or malignant tumors of the adrenal glands that will produce excess cortisol, again here the cause doesn't lie in the pituitary gland. And if there is a tumor, for example, carcinoma of the bronchus, small cell carcinoma, or carcinoid tumors that are producing ectopic ACTH, which is stimulating the adrenal glands to produce cortisol. So in these situations, the hypercortisolism, we call it as the Cushing syndrome. So the major difference here is that in Cushing disease, the ACTH is produced by the pituitary adenoma, benign tumors in the pituitary gland, which causes hypercortisolism, and we say it as the Cushing disease. But here the hypercortisolism is not caused by the pituitary adenoma, but either it is due to excess intake of corticosteroids, or the problem is in the adrenal gland, or there is another gland that is ectopically producing ACTH and that is causing hypercortisolism, and this situation we call it as the Cushing syndrome. Here is a condition known as the Nelson syndrome, which is a type of aggressive corticotropsil adenoma. Here what happens that the patient suffers from Cushing syndrome leading to hypercortisolism, and in this situation there is no problem in the anterior pituitary gland, but there is a tumor, for example, in the adrenal glands, and the adrenal glands are producing excessive cortisol. Excessive cortisol will give rise to Cushing syndrome and some serious complications associated with Cushing syndrome, and sometimes it is needed that the adrenal glands should be surgically removed. When the adrenal glands are removed, the feedback effect of the cortisol on the pituitary finishes. There is no cortisol to inhibit the secretion of the adrenocorticotropic hormone. So what happens that if unfortunately that patient was having a previous small microadenoma, so here after the surgical removal of the adrenal glands, the inhibitory feedback effect that is caused by the cortisol, that is completely lost, and in response the previously pre-existing small pituitary microadenoma, it will become overactive, hyperactive, and will lead to an aggressive corticotropsil adenoma. The cell will undergo hyperplasia to compensate because the pituitary doesn't know that there are no adrenal glands. It will be secreting ACTH to increase cortisol secretion. And if unfortunately there was a symptomless microadenoma that was present in the anterior pituitary gland, it will become a large aggressive corticotropsil adenoma, and this is known as the Nelson syndrome. So Nelson syndrome is the development of an aggressive corticotropsil adenoma from a previously existing microadenoma in patients in which the adrenal glands are surgically removed for some form of Cushing syndrome. The rare pituitary tumors, the gonadotropin producing tumors, they are rare, and mostly their effects are related to the presence of mass lesion in the anterior pituitary gland and include headache, diplopia, and sometimes pituitary apoplexy, in which bleeding occurs inside the pituitary tumor, and that is a neurosurgical emergency. TSH producing thyrotropsil adenomas are very rare, and they may cause excess stimulation of the thyroid gland by the TSH and will lead to excess production of thyroid hormones like T3 and T4. The non-functioning pituitary adenoma, they do not produce hormones. They will have their mass effects, and mostly in these non-functional pituitary adenoma, that will suppress the functional capacity of the pituitary gland and will lead to the underproduction of the pituitary hormones or hypopituitarism. The malignant tumor or pituitary carcinoma are rare tumors, and uh, mostly these patients are diagnosed when there are distant metastases. So, as a summary of the pituitary tumors, prolactinoma will lead to amenorrhea, galactorrhea, loss of libido in both sexes, and also infertility issues. Growth hormone will cause gigantism in children and adolescents, while acromegaly in adults, and there is associated uh, impaired glucose tolerance due to increased gluconeogenesis or increased glucose formation and insulin resistance, and it will lead to diabetes mellitus. Corticotropsil adenoma will cause Cushing disease, and additionally, the secretion of melanocyte stimulating hormones along with the adrenocorticotropic hormone will cause hyperpigmentation or black coloration of the skin with excess melanin pigmentation. The non-functional pituitary adenoma that mostly exert their effects by the presence of a mass in the uh, sella turcica, and most of these tumors later on suppress the functional pituitary gland tissue and may lead to the hypopituitarism. Thank you very much.